working at a Bambino Gesù in Rome, and I was also in that Kids College Hospital from 2009 and 2011, and then decided to go back to my city, Rome. I'm talking today about rejection. That remains one of the most severe complications in solid organ transplantation. So an early recognition of rejection allowed to promptly treat the rejection and consequently preserve the graft function. Since the first pediatric renal transplantation in the late 1950s and the first pediatric transplantation performed in the United States in 1976, the overall graft and patient survival increased significantly. And the success of this pediatric transplantation is mainly due to the advanced surgical technique that we see before, and also to for the new immunosuppressive therapy. Rejection is a very complex immune system mechanism that is predominantly mediated by the T cell. Following an organ transplant, the alloantigens are released into the circulation, and endotoxicite in the antigen-present T cell, the P cell, they travel to the second lymphoid organs, and the antigen peptide are loaded on the MHC complex that trigger the intracellular pathway to promote the gene transcription of several cytokines like IL-2, IL-15, and IL-21. And those promote and induce the T-cell proliferation through the mTOR pathway. So the knowledge of this complex immune mechanism allowed to create a new drugs, immunosuppressive drugs that targeted different steps of this immune cascade. So that reduced the incidence of rejection and improved the long-term of the graft and the patient. So there are different types of rejection. Hyperacute, that now is very rare, was due to the preformed donor antibodies that immediately in post-transplant binds to the graft, leading to the graft failure. But since the routinely used of the cross-match, they measure the reactivity of the patient donor cell with the donor cell, makes the hyperacute epitope very unlikely. And then we have the acute rejection, of course, during the first months after transplantation, and also the antibodies-mediated rejection and chronic rejection that is leading to graft failure and retransplantation. But it's not an issue that we're going to talk today. The treatment of acute rejection begins immediately post-transplant, and the mainstay therapy remains a high dose of steroid, usually 3 doses, we use 10 milligrams per kilo, and high level of calcium inhibitor like tacrolimus or cyclosporine. And most of the centers now use induction agent, monoclonal and polyclonal antibodies. The most used is basiliximab, is an IL-2 receptor antagonist that, compared to the others, show they have a lower risk of infection. Basiliximab is a IL-2 antibody, so inhibit the IL-2, the T-cell proliferation. And in some center, like our center, the use of basiliximab is also try to eliminate the use of steroid post-liver transplantation. And those are depending on the weight and the age, and is given on the reperfusion and on the day 4. And the inhibitor effect of basiliximab persists for 3 to 4 weeks. Already several studies on pediatric liver transplantation shown the efficacy of the basiliximab to reduce the acute rejection as well on the renal pediatric transplantation. The maintenance immunosuppression for the treatment is mainly used double, many centers use a double or triple regime that include the steroid and then one of the two of calcineurin inhibitor like tacrolimus cyclosporin and one of the MMF or azathioprine. So the common choice of on the solid organ transplantation remain the tacrolimus that is been shown to be more potent and efficacious compared the cyclosporine. And calcineurin inhibitor prevent the production of IL-2 and so the T cell activation and proliferation. And we want a high level in the early phase of the post-transplant, and then we gradually reduce the dose to minimize the toxicity that we already seen that the main adverse effects are the nephrotoxicity and neurotoxicity. Diagnosis of acute rejection is made on biopsy and on histological findings. Clinical symptoms are quite uncommon. You can have fever, malaise, hepatomegaly if we're talking about liver transplantation, or hypertension if we're talking about renal transplantation. And as well, conventional organ function markers are not very efficient. In liver transplantation, you can have the liver function that increase also during infection or ischemic injury or reactivation on the underlying disease. And as well, in renal transplantation, small children receive adult-sized allograft, and that makes them to have a large renal reserve with a delay of creatinine value raise. So these are the histological features that you find on the biopsy for liver rejection and liver transplantation, and that include portal and bile duct inflammation and endothelialitis. That is more specific feature for liver transplantation. And as well, for renal transplantation, they use the Banff classification, and the classic feature you find for in acute rejection is tubulitis with interstitial inflammatory cell infiltration, arteritis. The first choice of acute rejection remain pulse-sized dose of steroids, 3 doses. We use 10 to 12 milligram per kilo, and then followed by a slow taper. And it has been shown that the steroid reverse the episode of rejection in 60 to 75% of the cases. The patient is considered resistant if he's unresponsive to this pulse high-dose steroid with a good level also of an immunosuppression. And so different hospitals have a different rescue therapy. Those are the drugs that usually used on the SSR rescue therapy. We already talked about the sirolimus that binds the mTOR, so inhibit the cytokine-driven T cell proliferation. MMF, block the purine nucleotide synthetases, and then the ATG, that causes the depletion of the T cell, and the IL-2 receptor antibody as basiliximab. We can also have late acute rejection. It occurs usually after a year of post-transplantation. It's mostly related to a not good compliance of the patient, and that can cause a high risk to progress to chronic rejection and graft loss. As well, the recurrent acute rejection can have the same problem, and the management include increasing the level of the baseline immunosuppression with or without the addiction of a new immunosuppression drug. This is more antibody-mediated rejection is more for kidney transplantation. It's driven mainly by the B cells and complement activation, and is well known that is a risk factor for decreased graft survival after kidney, heart, pancreas, and lung transplantation. Liver seem to be resistant to the DSA-mediated injury, but the mechanism is why is not clear yet. So now the preformed DSA is less common to have acute mediated rejection, but it's mostly de novo or non-HLA antigens. And the new approach, the fluorescence, allowed to detect a low titer of the HLA antibodies, and it is expressed as a mean fluorescent intensivity. In 2003, a conference defined the renal criteria for AMR in kidney transplantation that include histological evidence of acute tissue injury, the C4 staining within peritubular capillaries, and the evidence of DSA. In liver, it's less studies because the incidence is low, but we have also criteria for that that include as well histological pattern of injury, the presence of DSA, the C4D staining deposition, and also the exclusion of other potential etiology of allograft dysfunction. In liver biopsy, CD4D deposition was also found in the patient with de novo autoimmune hepatitis or recurrent of HCV infection. There is not treatment proven to be effective, but most of the center use a double approach. One is to remove the harmful antibody from the blood through the IVIG and apheresis, and the second is agent that modulates the specific immune response involved in the AMR. So the treatment is still evolving with and now at the moment, no optimal dose or best strategy are found. Also because the randomized control trials are rare, and as well the diversity of the therapeutic protocol using different kind of medication makes it difficult to attribute to one of the single agent the effect. Those are the treatment usually used in AMR. So we have the rituximab, there's an anti-CD20, there's a marker on the B cell, and then we have the proteasome inhibitor, the bortezomib that is inhibit the plasma cell, and then the anti-C5 eculizumab that inhibit the complementary activation, and the newest agent, the belatacept, can inhibit the co-stimulation blocker. So, like we said, the current episode of acute rejection and late acute rejection could lead to a graft dysfunction and graft loss. So an early detection is paramount important to improve the long-term outcomes. And the method we have now is the surveillance biopsy and non-invasive markers. So protocol biopsy is the gold standard to evaluate the graft health, and in some center they have serial biopsy, predefined intervals after transplantation, performed regardless of the graft function. To detect the subclinical rejection. In the past years, many centers reported that in 10 years post-transplant biopsy, they found subclinical inflammation and fibrosis. So protocol biopsy could be a precious tool to proactively optimize the immunosuppression therapy. Of course, protocol biopsy could be invasive, but the risk is quite low. And then now the many studies are focusing on non-invasive markers, and the graft-derived cell-free DNA has been shown to be a promising marker to detect the graft injury. And since the organ transplant are also genomic transplants, the GCF DNA could be a potential marker for organ integrity. It's measured by droplet digital PSR and expressed as a percentage. And in some study, showed to be the GCF DNA that allowed an early detection of acute rejection as a liquid biopsy. On the left, there is a study on a heart transplantation patient, adults, where they where on 112 subjects, where they found a percent of donor DNA raised on rejection compared to the healthy patient. And this is a study on liver transplantation, adults as well, where the DNA percentage was raised, significantly raised compared to the stable agent, and as well was significantly raised also 8 to 15 days prior to the biopsy, improving acute rejection. Then we have the Immuno that was approved in 2002 by the US FDA as a cell function test for assessing the immune cell response, and Immuno measure the intracellular ATP in the CD4 T cell as an indicator of immune cell function. And in the study in solid organ transplantation, reported that immunoassay is better for predictor for infection than for acute rejection. In our center, we not use anymore. Cytokine and chemokines are also involved in inflammation and on T cell function, so they could be a potential marker to be used as either diagnosis or prognostic biomarker in patient followed solid organ transplantation. There are several studies that show that cytokine and chemokines are raised during the acute rejection. Those are some of the interleukins and chemokines studied in renal, as well in liver transplantation. And the last is a microRNA that has a property to be raised early in the tissue injury. So it could be a ideal biomarker to detect the graft injury, and is also raised in the microRNA in urine and in serum in renal and liver transplantation. So, take-home message are that rejection remain one of the most feared complications in solid organ transplantation. So an early detection and optimal management is paramount to improve the long-term outcomes. And study should be focusing on non-invasive monitor markers to help the management of the rejection. But data, clinical study are not yet show that. Oh, thank you.